All right, it is 10:01. I think everybody should have been able to jump on and get their audio connected. So we'll go ahead and get started. Thank you so much, everyone, for joining us today at the Opioid Conference. I hope you enjoyed the opening session as much as I did. That was a great opener. If you would just remember to please mute yourself as you enter the room, your mic will be unmuted. So if you would please mute yourself and keep your audio on mute unless Jonathan asks you to unmute for any reason, that'd be really helpful for us. So thanks for joining us for the international comparison of postoperative pain management in orthopedic patients. That's a mouthful. I would like to start with just a couple of reminders. This is being recorded, and an hour after the session, the recording will be available on the platform. As I mentioned before, please keep yourself muted. Make sure to join sessions live today, as we'll be doing prize drawings for attendance with each one of the sessions. The conference is also offering free continuing education credits. So for more information about receiving those credits, you can go to the platform homepage, and there's a tab saying continuing education page. If you would go to that, you can find the information that you need. So I'm excited to introduce to you today's speaker, Jonathan Dahlman. Jonathan, hang on, let me mute somebody, sorry. Jonathan is a second-year medical student at the University of Kansas School of Medicine in Kansas City, Kansas. He first received his Associates of Science degree from Highland Community College before receiving his Bachelor of Science degree in chemistry from Kansas State University. At the University of Kansas School of Medicine, Jonathan is the co-director of the musculoskeletal clinic at JDOC, one of the largest student-run free health clinics in the nation. His current research efforts include numerous topics surrounding orthopedic trauma, orthopedic sports medicine, as well as examining both bone health in the transgender population. Sorry. In the future, Jonathan hopes to merge his interest in musculoskeletal health, working with underserved populations, and pain management, and becoming an orthopedic surgeon. So thank you, Jonathan, and take it away.
Thank you so much. Again, today we are going to be kind of talking about international comparison that a group of medical students and physicians at the University of Kansas has conducted, comparing post-operative pain management in orthopedic patients. Before we really begin, I definitely have to give a thank you to the research team. Jack and Jack have really been instrumental in my first year as a medical student and guiding the way as I've continued medical school. Dr. Soika and Dr. Headings have been excellent mentors. And then I have not been able to meet Dr. Malencia in Romania, but I've heard great things. And we also had Nicholas Higginbotham also help with this research. So a huge thank you to all of them. For today's session, though, we are gonna kind of want to revisit how different pain medication management work. It's kind of maybe the more boring part of the talk, but it'll help nonetheless. Then we want to dive into understanding pain management protocol differences between the United States and Europe or Romania, followed by how different pain medications work depending on the environment. And when I say environment, looking at specifically sex, age, whether there's other medications involved, anything like that. And then we want to recognize the pros and cons to different pain management strategies, specifically what we're seeing between the United States and Romania. So we're going to kind of divide this into somewhat of a research type format, where we're going to kind of go through a little bit of background, followed by how we really analyze the data between the United States and Romania, followed by results, and kind of discuss what the difference is and the results are. There is a poll on the platform. I think there's like 4 polls if you're interested in going and taking your time to go look at those, kind of quiz yourself before we go through everything today. But I will kind of preface throughout today's talk, I'll be mentioning or referring a lot to the literature, which refers to other research that has been published by other institutions regarding pain management, opioid use, as well as non-opioid use. And there's a list of references at the end that we will all present to everyone. But nonetheless, we're going to kind of dive in. To begin, the post-operative pain management and orthopedic departments around the world has really been a constantly debated topic. It is clear that orthopedic injuries and orthopedic treatments carry significant pain and morbidity burdens, but protocol outcomes differ just throughout the world. These results here is a 2013 study that compares post-operative pain management between United States hospitals, which is there on the left, showing 98.3% of US patients receive opioids, versus European patients where 70.2% received opioids. With this said, though, the study concluded that US patients had significantly worse reported pain than European patients, even though we are giving way more opioids. So we will come across this question multiple times throughout this session, as well as a lot of information that kind of supports the use of opioids and quite a bit of information that also kind of refutes the use of opioids. And no matter where you sit on this topic, from a research and scientific standpoint, one must really question the reason for the wide use of opioids here in the United States, whether it's a cultural or a protocol thing here in the United States, or whether there's a thought within the patient population as individuals feel they need opioids, or the thought that opioids are superior pain medication management. And we're just going to kind of dive into some of those thoughts throughout today's talk. But in order to really discuss the different pain managements, we're going to kind of go through and just get a generalized background of how each pain management technique works. So how opioids work versus how acetaminophen work. And these are just short, like 1.5 minute, 2-minute clips that we will watch super quick. Let's see. Okay, so to begin, this one's over just opioids, a quick 2-minute background of opioids and how they work. It'll give a background for the rest of the talk, as well as probably the rest of today's sessions that you'll be seeing in the future.
Science, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss opioids. The term opioid refers to substances that bind to opioid receptors, usually to exert pain-relieving effects. Opioids can be found naturally in the opium poppy, or they can be partially or completely synthetic. In addition to pain relief, opioids also cause sedation, anxiety reduction, and euphoria, along with a variety of other effects. When opioids bind to opioid receptors, they promote potassium conductance, which makes a neuron less likely to fire an action potential. And they inhibit calcium conductance, which makes a neuron less likely to release neurotransmitters. What effect these actions have depends on where the receptors are found. When opioid receptors on neurons in the spinal cord that carry information about pain are activated, it can inhibit the transmission of pain information to the brain. Opioids can also act on descending pain modulatory systems to reduce pain. For example, by binding to receptors in an area of the brainstem called the periaqueductal gray, opioids can prompt the inhibition of pain signaling in the spinal cord via a pathway that first synapses in the medulla. Opioids can reduce the emotional impact of pain by acting in brain regions like the anterior cingulate cortex, and they increase dopamine levels in areas like the nucleus accumbens, which may contribute to the reinforcing qualities of the drugs. Exposure to opioid drugs leads to tolerance, which involves a decreased response to the drug and a need to take more to produce the same effect. The mechanisms of opioid tolerance aren't fully understood, but they're thought to involve adaptive changes like a reduction in the number of functional receptors for the drug to act at. Adaptations in response to the presence of the drug also lead to dysregulation when the drug is removed, and withdrawal effects that are opposite in many ways to the typical effects of the drug.
Okay, so that's the opioid one, and then we're going to look at a short video over acetaminophen. This one's a little more in depth than what we really need to know, but it's a good video nonetheless.
Paracetamol is an over-the-counter OTC analgesic and is recommended for the treatment of fever and mild to moderate pain, such as headache, migraine, toothache, musculoskeletal pain and dysmenorrhea, and osteoarthritis pain. Within the pain matrix of the brain, paracetamol inhibits COX-1 and COX-2 with apparent selectivity for COX-2. Paracetamol blocks the physiological regeneration of the POX-active site, which inhibits the reduction of prostaglandin G2 to prostaglandin H2. This inhibits overall production of prostaglandin E2. Paracetamol also inhibits peripheral COX-2 to a lesser extent. Primary inhibition of COX-2 by paracetamol is central in the brain, where peroxide tone is low. Recent studies indicate that paracetamol can activate central cannabinoid CB1 and vanilloid receptors to relieve pain. Paracetamol also inhibits peripheral COX-2 to a lesser extent, where peroxide tone is high. Pyrogens are fever-inducing substances that increase the concentrations of prostaglandins in cerebrospinal fluid and mediate paresis. This increase is blocked by paracetamol to set a lower body temperature and relieve fever. Paracetamol primarily has a central mode of action with limited peripheral effects and no anti-inflammatory properties.
Okay, great. So that's a little bit of background. Let's see, are we back? I think.
Nope, it's not seeing your screen.
Not.
You have to reshare probably.
Sorry about that.
No problem.
How about there?
Looks good.
Okay, so the biggest takeaway from these two videos is just knowing kind of the basic mechanism, knowing opioids result or act on mu receptors, and acetaminophen works on COX-1, COX-2 enzymes, but ultimately opioids and acetaminophen alleviate pain in different ways. And there was a 2019 review that kind of discussed how NSAIDs, when used in conjunction, or acetaminophen when used in conjunction with opioids, actually reduce the amount of opioids that are needed to produce a significant amount of pain reduction. So, and that kind of makes sense, knowing opioids are working to fight pain in one way, and then acetaminophen and NSAIDs are working to fight pain in another way. Another type of medication that we're going to look at, these are specifically two medications that are used quite broadly in Romania, diclofenac and metamizole, and they work similar to how acetaminophen works. Specifically, they also block COX-1, COX-2, which in turns blocks the prostaglandin H2, followed by prostacyclin, prostaglandins, thromboxane. Similar pathway. Diclofenac acts as an analgesic, antipyretic, anti-inflammatory, antiplatelet. So again, very similar to what we were discussing earlier with acetaminophen. It should be noted that metamizole is also an NSAID. However, it is currently banned in the United States due to its risk of agranulocytosis, which is pretty much the killing of a lot of your white blood cells and puts a patient at risk for infection. With this said, though, it is still widely used in the United States for veterinary medicine, and it's also used in human populations in other countries, including Mexico, Romania, some places in Europe. So it's still widely used. It's just not used here for human treatment due to that one significant side effect. But to kind of just jump in, why did we do this research? I don't think anyone here needs a reminder on the significance of the opioid pandemic or epidemic. In 2019, 70,000 people died from drug overdose. 1.6 million people misused prescription pain relievers for the first time. And then 10.1 million in 2019 misused prescription opioids during that past year. And in light of the well-reported shortcomings of the US health system in effectively managing post-operative pain and the grave dangers of its reliance on opioids, it's really worth investigating more in depth the relationship between non-opioids versus opioid pain control and the respective effects on patient-reported outcomes. So the study that we performed was actually developed during the summer of 2019, while a co-investigator was actually at the Romanian institution for educational exchange program. And when he was analyzing the Romanian perioperative protocol, he was able to recognize that the pain management that they do over in Romania is very different from what we do here in America. And though you can see that there's differences here, it remained to be unclear on whether these differences in protocols on the differences in these post-operative protocols actually changed patient-reported pain outcomes. So by better understanding the differences and their respective effects, we can might be able to provide valuable context for current discussions and optimize pain management here and in Romania, and kind of drive future research in where should we be going with pain management. But in order to do this, we really had to look into, or we really had to design or look into how we were going to study this. So kind of just looking at the study design, patient population that we were looking at, as well as the statistical analysis that we were used to compare the two populations. Specifically, the study design, we looked at patients from May 23rd, 2019 to November 23rd, 2019. We looked at two different locations, one in Batsani, I don't know if I'm pronouncing that right, but Romania, and then the other one here at the University of Kansas Medical Center in Kansas City. Anyone that's interested in where Romania is, it's in Europe. It's this smaller portion here is where Batsani is. And looking at the hospital differences, this is the hospital in Romania versus if anyone has not been to University of Kansas Medical Center, this is what's here in Kansas City. So a little bit different place to practice medicine, I guess. For data gathering, we were looking at, in Romania, we actually gathered the information real time. So as patients came in with the injuries, we were getting the pain scores, seeing what pain medication they were on, everything like that, as the patient was in the hospital. For the United States, however, we went back into patient charts and actually pulled data retrospectively from the patient's charts. We did that last year, so it was a year after these patients were actually in the hospital. We specifically looked at different patient populations and the surgical treatment for pretty painful injuries. These specific injuries, the bimal ankle fracture, which treatment is shown here on the right with plates and screws. Also, we looked at distal radius fractures, femoral neck fractures, hip arthritis treated with total hip arthroplasty, or other words, hip replacement, intertrochanteric fracture, which is shown, treatment shown here on the left, tibial fractures with associated fibular fracture. So ultimately, what you can kind of pull away from this is we're looking at some pretty significant and pretty painful injuries that needed good pain management. And we specifically looked at these because these were the numbers at both institutions that had significant enough patients with these injuries that we could actually compare the two populations. Also, for individuals to meet our inclusion criteria, they had to be at least 18 years old. They had to have documentation in the first 24 hours after their operation, as well as the second 24 hours after their operation. And then looking at the number of participants that were seen in Romania, we originally had 556 patients for which data was collected on. And then after determining the injury pathologies for which there were a significant number, which are the 6 injury pathologies up here, 282 patients met the criteria. And then lastly, we had to exclude 38 from the Romanian cohort due to them not having a pain score in either the first or second 24 hours, leaving us at 244 total. In the United States, we originally started with 728 results that were retrospectively pulled from the charts. From there, we had to eliminate all the patients that did not have these specific injuries, which left us at 317. And then we had to exclude 131 due to them being discharged before 48 hours post-operatively, or they did not have documentation of the pain score in the first 24 or 48 hours. And that left us at 184 United States patients. So that's kind of how we gathered the patients for this study. Just looking a little background on how we compared the two populations for categorical data. We use the Fisher's exact test and odds ratio with a 95% confidence interval. Just a little background for categorical data. It's data that you can be grouped together. Continuous data, we use t-tests with a 95% confidence interval. And just a reminder, it's data that can't be grouped together. It's kind of continuous, as you can kind of put together. And then just some other data, a p-value of less than 0.5. That's how we determined if something was statistically significant. And then we used a specific software called R version 3.6.1 for our analysis. And now we are finally ready to get into some of the more interesting stuff, the results and discussion of what we saw in the two patient populations. So to begin, we're going to look at the patient demographics, just see if there's any significant difference that could cause the difference in pain scores that we will see later. Looking at the age at injury. So comparing University of Kansas versus Romania, Romanian patients were slightly older, but ultimately they were approximately the same age. The female sex was more prevalent in University of Kansas or United States patients. And then looking at injury type, hip arthritis, more common in the University of Kansas. Romania had more intertrochanteric fractures. Distal radius fractures were pretty equal. And then femoral neck, bimal, and tibial shaft fractures were more prevalent in Romania. One note that we should make here, though, is these numbers only really represent patients who have stayed in the hospital for 48 hours or longer and received both their pain scores. Here in the United States, a lot of orthopedic surgeons see way more femoral neck fractures than 4 in a 6-month period. Specifically, a lot of them are from motor vehicle accidents or geriatric falls. However, here in the United States, a lot of times we will have the surgery done and then they're treated outpatient after a day or so. So they leave the hospital a lot sooner than what we're seeing over in Romania. And that brings us to the question, we saw, our patient demographics. So how does the pain management differ between the United States and Romania? If you remember in the introduction, In the United States, we had approximately 98% of United States patients versus 70% in Europe. It is a little worse in the comparison between United States and Romania. It is actually 96% patients in University of Kansas receive opioids versus less than 1% in Romania. And this just kind of shows how big of a mainstay opioids are here in the United States. If you're wondering what that equivalates to, it means 177 of 184 United States patients were treated with opioids, while 2 out of 244 Romanian patients were. And again, this brings up the question that needs to be answered in the near future about why is this? Is it due to, you know, our physicians that are just prescribing opioids, or is it due to the American population demanding to be treated with opioids, or just this innate thought in our culture that opioids are superior? You need opioids to handle fractures and stuff like that. And that's just something that we'll have to dive into in future research, unfortunately. But looking at medication utilization, United States versus Romania, there was no significant difference in the amount of opioids that were given to United States patients in regard of sex or age, while, and that was similar in Romania, that there was no significant difference between males and females in acetaminophen, diclofenac, and metamizole. And there's no significant difference in terms of age with that too. One thing to note is this kind of contradicts what was found previously in the literature. There was a United States study done between 2008 and 2018, and their conclusion was that opioid prescription fill rates were disproportionately higher in the geriatric population and women of all ages. And what we found here clearly is that in both countries, that there was no difference in the amount of opioid or non-opioid analgesics given with respect to sex or age, which contrasts what is previously found in the literature. One significant thing that we found here in the United States, though, is when you compare or when you look at acetaminophen and the individual's age, it appears that as an individual age, they are more susceptible to acetaminophen, or acetaminophen works better for them. So, and you can just see by this graph here that as a person ages, you know, acetaminophen works better. And that was, I don't know if that was previously reported or not, but it is a significant finding that we did find from our study. Furthermore, we were able to look and kind of confirm what was previously we talked about earlier, is that when you combine opioids with NSAIDs, or in this case, acetaminophen, it really significantly drops the individual's pain score. So, and it also drops the amount of opioids that needs to be prescribed for an individual to have pain relief. So, in combination, they have to have some sort of synergistic effect, and they work in combination. And that might be due to the fact that they work on two different types of pain modulators in the human body. One of the biggest findings in Romania, though, which we didn't see in any of the medications in the United States, is independently diclofenac affects pain scores. So it doesn't matter on age, sex, injury type, what medications it's paired with. Independently, diclofenac does help with pain. And we didn't even see that with opioids, which is a very interesting finding in and of itself. But pretty much everything else was pretty insignificant. As you can see here, didn't really matter what the pain injury was or the amount of metamizole was given. You can see just the lines were kind of going all over the place. So ultimately, the effect of most of the other medications did not depend on sex, injury type, or dosage of other medications given at the same time. So it just kind of confirms that what we're finding is actually significantly different, and there's different things that really don't matter in regardless of the patient that you're giving them. With this said, though, for subjective pain alleviation, our findings suggest that opioid use in the first 24 hours post-operatively seems to improve pain, which you can see here. But this effect is actually reversed in the second 24 hours with the Romanian patients who were predominantly treated with non-opioid pain medications that demonstrated better pain control. And it should be noted that this is probably likely to be from many different factors that contribute to this finding, some of which may be inherent to the selection of the patients in this study who had to be in the hospital for bare minimum 1 day. The authors also speculate that, we also speculate that the one major contributor may be differences in managing patient expectations of post-operative pain. There has been previous attempts of actually going and educating or talking to the patient, being like, you injured your leg, you broke your leg. We can give you opioids. It's going to help you feel better, but no matter what, you're going to still be in pain regardless of the amount of opioids we give you or amount of pain medication we give you. And this has been shown in some studies to actually affect the pain scores, causing them to drop, causing us to not have to prescribe as many pain medications, while in other studies, it shows that no matter what you say to the patient before or after treatment for their injury, it doesn't really matter. They're still going to have high pain scores, need a lot of pain medications, stuff like that. And additionally, just due to the fact that the US did have a lower pain score in this first 24-hour period, indicates that this finding may not be easily explained by just one thing in either of the countries. So we just need to kind of dive into more of why we're seeing this. And this could be due to one of our limitations. We're not sure. Future studies will hopefully provide light in this. And some of our limitations of the study that I just want to kind of address and bring up first is one, measures of pain relied on patient-reported subjective pain scores. And this could be inherently biased due to patients' desire to get more medication and the natural disadvantage of just self-reported pain scores. There's a variety of reasons for that. And then secondly, due to the difference in the non-opioid analgesics used between countries and due to lack of standardization amongst non-opioid analgesics in general, it was not possible to quantitatively compare the non-opioid analgesics administered between each country and between injury pathologies. And this is something that we're going to have to tackle in the future. When you look at opioids, you can convert them into morphine equivalents. So you can technically compare all opioids across the spectrum. But when you're looking at acetaminophen versus ibuprofen versus diclofenac, there's no standardization saying, this much diclofenac equals this much acetaminophen, like you can with in opioids. You can be like, this much hydrocodone equals this much morphine. And that's something that really needs to be tackled in the near future, so we can really identify how much pain medication or compare pain medications better. Thirdly, though, in order to provide accurate comparison of patient-reported pain outcomes, patients were excluded if they were discharged before the 48 hours post-operatively. And accordingly, the patients included in this study may have had relatively more pain and or more complications because they're staying in the hospital longer than the people that are discharged within the first 24 or before their 48 hours. And then lastly, just due to the retrospective nature of this study, the data is reliant upon proper documentation and charting, which we all hope and think that, charting and everything's getting done appropriately, but it is nonetheless a limitation of the study. Now I kind of want to dive in and kind of discuss some of the differences that we just saw in the results. And one of the big questions is, how does the postoperative pain management protocol differ in medication selection and dosage between orthopedic trauma departments at the hospital here in the US, University of Kansas, versus the hospital in Romania? And to kind of answer this, we first have to look into how the United States is the first in the world amongst high-income countries for the number of opioid prescription per capita. We have about 50,000 prescriptions per million inhabitants, and it was steadily increasing for a while, but we kind of leveled out at 50,000. And then although recent reports kind of raised concern about increasing reliance on opioid in Europe, leading some question to whether Europe could be heading to its own opioid crisis. With this said, especially in Romania, European opioid use still pales in comparison to what we're doing here in the United States. And accordingly, the finding that nearly every patient in the United States cohort was administered an opioid-containing pain control regimen, it's really unclear whether there is an aversion to opioids in Romanian hospitals, or if there's some sort of cultural, economic, or political factors that simply have just not caused the nation to be ready or susceptible it's more susceptible to opioids like here in the United States. There's just a variety of reasons that could be playing a part of that, or maybe they just could be trying to stay away from opioids as much as they can. Next, do disparities in postoperative pain management protocol exist within either department? So just to kind of highlight the study that that I analyzed earlier, between the 2008 and 2018, opioid prescription fill rates were disproportionately higher in the geriatric population and women of all ages. However, in our study, both countries in the study, that there were no significant differences in amount of opioid or non-opioid analgesia given with respect to sex or age, in contrast to this study that was reported in the literature. So there's a little bit of conflicting information there. And again, this is different for acetaminophen, which just kind of hammer home as an individual ages, acetaminophen does become better for pain alleviation. So that's just a major statistical finding that we did find, that just kind of want to hammer home, make sure that's a big takeaway for this study. And then I think the main last discussion point for our project was, do disparities in postoperative pain management outcomes exist within the two departments? And this is arguably the biggest finding, which we haven't discussed yet, but it's that sex was significantly associated with pain scores in the United States, as females had higher pain scores than males, while sex was not significant in Romania. And that makes us kind of wonder, why is this? And you can argue, it's the physiological ramifications of sex, or there's a cultural relationship between pain and sex. But this finding, ultimately, in the United States, or in the US, women having higher level of pain after orthopedic procedures is actually supported in the literature in terms of total joint replacement. Women have been reported having higher levels of pain. 2020 review of sex and gender differences in pain management reports that there are sex-based physiological factors that may be related to differences in pain perception and responses to and or inhibition of painful stimuli. also sex hormone production, neuromuscular control, inflammatory responses, and comorbidities with notable sex-based discrepancies, which may contribute to pain management. Ultimately, that the effect of sex varies between the United States and of Romania suggests that there could be a gender-based cultural or societal impact on pain. And it is reasonable to kind of suggest that the cultural variances between United States and Romania related to these entities of cultural and societal interaction with pain management may explain the discrepancy that we kind of found in our study. Another notable finding for US patients was that neither the effect of opioids or non-opioid analgesics was dependent on sex, while the finding does refer to, refers to sex and not gender, this may also speak to cultural, societal ramifications of how the pain management, as it's reported that opioids may in some way be less effective in women. One example, which has been reported in the literature, is that women could have a lower density of mu opioid receptors, which is, as we saw in the mechanism, is how opioids work to lower pain. There also has been reported higher rates of opioid abuse in women compared to men, and this could just be a surrogate for poor pain control in women for those that are prescribed opioids. And then finally, it's kind of worth noting also that in Romania, the diclofenac dosage was found to be independently significant in terms of effect on patient-reported pain scores, which we didn't see with the opioids. So is diclofenac maybe the better pain management medication than opioids? More research needs to be conducted in that realm. Additionally, in the United States, it was discovered that there was a two-way significance looking at acetaminophen and opioid use, how the more, or when you use them in conjunction, you don't have to use as much opioids to achieve a specific pain alleviation. And these findings kind of highlight the role of non-opioid pain medications in the postoperative pain management. And there was, again, another study recently done that just confirmed that the use of NSAIDs with opioids in turn can lead to a reduction of opioids by approximately 50%. And then that same study also looked at diclofenac utilized with opioids, and that leads to reduction of opioids between 17 to 50%. And that is kind of maybe a way to start using less opioids here in the United States. So in conclusion, opioids use in the first 24 hours appeared to improve pain control, but this effect was lost in the second 24 hours, which in turn is just important to also highlight that in the United States, female reported higher pain than in males, despite being given a statistically equivalent amount of opioids. Yet in Romania, male and female scores were statistically equal. And this finding suggests possible cultural differences between the United States and Romania as it relates to pain control in female patients, and furthermore suggests that pain management protocol here in the United States, it could actually just be more tailored to the needs of male patients. But as this discussion over the use of opioids continues, these findings that pain management is a complex process. It involves a variety of variables, including other medications, the sex, the age, the gender, as well as the culture of the patient. And further research needs to be performed in order to really understand the most efficacious pain regimen suitable for all patients. Furthermore, numerous questions need to be answered in the near future about why United States patients are receiving such a higher rate of opioids. Is it due to just giving out us our protocol just being of giving opioids, or is it more, again, the American population demanding opioids with the thought that they are the superior pain medication? And ultimately, more research just needs to be performed to determine if opioids provide enough pain relief for us to really continue utilizing them in this high demand. And again, today's session's kind of takeaways is revisit how how different pain management medications work. Opioids, again, the mu receptor, NSAIDs, acetaminophen are very similar. Looking at the COX enzyme, we wanted to understand pain management protocol differences between the United States and Europe and Romania. Here in the United States, we predominantly use opioids, while in Romania, they used predominantly diclofenac and metamizole. We also wanted to appreciate how different pain medications work depending on the environment. And it was shown that diclofenac significantly helps with pain regardless of what it's being used with, the population that it's being used on, anything like that. Acetaminophen is more helpful the older the patient is. And then amount of opioids needed can be decreased when used with acetaminophen. Lastly, we kind of want to recognize some pros and cons, but specifically cons to the United States pain management strategies. So one significant con that we've been dealing with for several years is the overall opioid crisis, but also this questionable pain alleviation over time, seeing how it's very helpful in the first 24 hours, but the second 24 hours, actually the non-opioid pain medication was shown to be better in this study. And then also the questionable efficacy that differs between sexes, seeing how in the United States here, women are experiencing some sort of disparity in pain control. And again, I would just like to really thank my co-authors who have made this research possible. Again, Jack and Jack, amazing. They're both planning on going orthopedic surgery. Dr. Soika and Dr. Headings allowed, making this research possible, as well as Dr. Melantia, and then Nicholas Higginbotham, also, a great guy. Again, we have references here for all the side papers. I think I uploaded in the files on this page, just the list of references if anyone's interested in looking at some. And ultimately, just want to thank everyone for being here, and I'm happy to take any questions that you may have.
Thank you very much, Jonathan. So if you have any questions, I would encourage you to put them in the chat. If you could use, if you have the platform open, the chat on there will be saved. So it would be appreciated if you could use that chat. And also, if there's somebody who wants to unmute themselves and go ahead and speak up, that would be fine too. Give you some time to think about your questions, and don't want to shut anybody off. So just give you a little time here. Also, those polls, if you go to where the chat is on the platform, at the top above the chat, there is a tab that says polls. You can click on that and answer those polls now that you've gotten the information that Jonathan has shared with you. And if you want to know the answers to those polls, maybe if you stick around, Jonathan will tell you. A lot of thank yous, appreciations. I haven't seen questions that have popped up. I think you answered them all. You did a great job. Thank you very much for your time and sharing this great study. And I hope that you continue forth and go forward and find out more and more that's going to be very useful to this important issue. Is there anything else, Jonathan, that you would like to share?
No, I don't think so. Not at this moment. We're looking to get this study published in the near future. So hopefully, 6 months from now, you can have the whole story in written context if you go out and look for it. So, but that's all. Thank you so much for everyone coming.
All right. Thanks, everybody. Have a great rest of your day and joining the next session. Don't forget, if you want CEUs, the information is on the platform there to how to access those. And that's all we have for you today for this session. Thanks again for coming and enjoy the rest of the sessions.
Thank you.